Today I will just briefly tell you about the combined method for tracheoesophageal fistula closure. We did it for the first time. 47-year-old lady, she presented with papillary CA thyroid. She underwent surgery in 2021. She had a local recurrence which was very advanced and bad tumor. In view of airway obstruction, tracheostomy was done in April 2022. For feeding purpose, thereafter PEG placement was done, 24 French, for nutrition. Later on, after 6 weeks of PEG placement, she developed cough and regurgitation of food contents through tracheostomy tube. First, we went ahead with CT thorax, which showed a tracheoesophageal fistula around 4 to 5 mm size at D3 level. Then an upper GI endoscopy was done to see the fistula site. Endoscopy, there was a slight narrowing in the cricoid region. The scope was negotiable with mild resistance. We went ahead with around 10 to 12 mm CRE balloon dilatation, and we tried to close the fistula with dummy cap, just to whether any clip we can place. We just thought like that. Since it was a thick mucosa and unable to grasp, it was unsuccessful. Hence, we planned for fistula closure with VST device. This is the post-cricoid stricture. There was mild difficulty, mild to moderate difficulty in negotiating. Could negotiate slowly. Then the fistula site was appearing around 20 centimeter. This was around small fistula, around 4 to, it's in the 5 o'clock position, around 4 to 5 mm fistula. Then we did a bronchoscopy and wire through the tracheostomy site. We did a bronchoscopy and wire was placed across the fistula. Wire was seen in the stomach. Then we introduced a 8 French sheath for AST device under gastroscopic guidance. This is the AST device we used. And deploying AST device, firstly we opened it distal most near to the stomach, then we proximally moved it. It was a good opposition on the esophageal side. Slowly withdrawing the device up to the site of the fistula. Once the perfect position and good wall opposition is confirmed, then we simultaneously did the bronchoscopy and just check the site of the way to release the proximal release through the tracheal site. It was fitting opposing correctly. Then while deploying through the tracheal site, because of the traction pull, there was slightly desaturation and lot of little bit aspiration was there. So we immediately suctioned it and we thought we would release. Once we released, the size of the proximal release of the this tracheal release stent was little bit more. It was slightly causing compression and stridorous breathing. So we went ahead once again the assembly, we have reassembled it once again. And because of pull, the device was more towards the tracheal side. It was less in the esophageal side. So we just proximally we released in the under gastroscopic guidance, just not as the initially distal most part, little bit proximally we released. And since the device was migrated, we just released it proximally under endoscopic guidance. Then we went ahead with trachea along with the push-pull technique. We just released the device. This is the esophageal release. We didn't release completely. There was a just mild distal most part. We just released it. Using the traction, push-pull, then we deployed the tracheal side. We confirmed the position and patient was doing good. And we check fluoro was done. It was showing good position. The next day, check fluoro was done. It was showing tracheostomy in tubu and the ASD device in situ. The device is in situ, ASD. So, post procedure, she tolerated well, and there was required frequent suctioning for 2 or 3 days. Then there with supportive antibiotics, she was doing good. We followed up the patient for up to 3 months. She was doing good. So briefly summarizing, cardiac septal occluders, either AST or VST device closures, are thought to promote fistula closure by occluding the fistula tract, and they stimulate the tissue ingrowth. Recent meta-analysis suggests it is an 100% technical success rate and around 77% clinical success rate and around 22% adverse rate. Whenever the other methods fail, I think then good option in managing GI fistulas or you can use cardiac septal occluders. Thank you.
That was a fantastic presentation. Only one thing is never send mobile pictures. Mobile. It was very. It's not a good way of presentation.
Fine.
Apart from that, the video was good. How do you? I saw the date was in 2000. It was done in year 2000. And now, what is the long term? We have done almost 7-8 cases, and none of them stay for long. Like 6 months, then they either vomit out that stent or they get aspirated. So what was your opinion about that? What happened?
First thing, sorry, date was like old system, it was not entered properly. For 3 months we followed the patient since she's a metastatic and bad recurrence and all. She was doing good up to 3 months. It requires frequent suctioning. Apart from that, she developed then some fracture and finally she expired due to other reasons. But for 3 months, this device was in situ and she did well, sir. No.
Yeah, so the message is when there is a metastatic CA and never do it for benign disease.
Yes, only.
So it's only for metastatic CA when the life expectancy is less, you can opt for this option because other options are also not there.
Not feasible.
Thank you very much. Any questions?